So we heard just incredible talk. Some of pictures, I mean, most of pictures I never seen. It's incredible. So now we are going back to a little reality. So real, but still more current status. And so I really appreciate your invitation. I'm coming almost every year now, and with SPF's support, we can make a lot of research. So I'm going to report. So now, let's see. I don't know which one is what. I said I know what I'm going to do, but sorry.
It's okay. It's me.
Technologically.
It's okay. Let's see. Let's try this again. See, it's loading up here. Give it a second here. And let's see this one. There we go.
Oh.
What did I do? I went the wrong way. Kira. Let's go.
I feel good.
There we go. That's our first one. That's our. Let's go back. There we go.
So
There we go. That's
which
the
one?
new
Which did you?
I
What did?
just click on this
What
one.
did you talk? What?
And let's try this one. Hang on. There we go. Now
Good.
it's working.
This one?
Yeah, the right one.
Okay.
Yes.
Very good. Sorry. Right. So we're going to talk about the PLS-specific clinical scale. This is made of a lot of centers, 20 multi-center studies, because PLS is so rare, just one or few centers cannot study enough patients. So we asked about 20 centers in the United States participate and study patient and develop new scale called PLSFRS. That's what I'm going to talk. So why do we study PLS? So obviously PLS affects only upper motor neurons and is the rarest form of motor neuron disease. Unlike ALS, survival is not an issue, but PLS causes lifelong progressive severe motor dysfunction. So PLS has never been included in any clinical trial in ALS. This is extremely frustrating for patients. So I'm specializing in ALS, and I do a lot of clinical trials in the past, but never put in patient with ALS. I mean PLS, excuse me. So clearly there is unmet need, and studying PLS will help us understand the pathogenesis of ALS, of course, but also develop treatment for those who have this disease. So I want you to look at one line. I know this is such a small line, but if you look at third lines, ALSFRS R, and can you see about the middle ALSFRS? The nutshell, if you use ALSFRS, good for ALS, but doesn't show much change with the PLS, even after 2 years, showing a small change. So if we use clinical scales such as ALSFRS for ALS, and if you use ALSFRS for PLS, just doesn't show changes because disease change very little with the time. So we thought we need a different scale, disease-specific scale, and some other disease such as so-called Kennedy disease, spinal bulbar, spinal muscular atrophy, they use ALSFRS, but again, same problem, changes so little. So we thought we should develop new clinical new clinical scale. So I was involved with ALSFRS, original ALSFRS years ago, and so I thought we should do same thing for PLSFRS. So this is the new PLSFRS. ALSFRS is now 12 scale, and each subscale has 0 to 4, so 5 levels. And we asked a number of patients who are seeing at the Columbia and asked our purpose and their suggestions, choosing language and words. And then we made some prototype of PLSFRS. Then we called 34 patients who are participating in PLS Cosmos studies. We call Cosmos studies because quantitative studies, cohort studies, and then we called them and asked what they think about this new scale, and the suggestions, changes, and so forth made. So we made prototype scales. So that's what you see. So what we did was the baseline. We did multiple studies, not just the PLS-FRS, also patient-reported scale called the NeuroQOL, which was developed at NIH and validated, and also Schwab-England scale and the clinical global impression of changes. All those scales used to validate new scale. So we used baseline, and 3 weeks later, again repeated, primary repeated, secondary did another studies, and telephone studies. The purpose is even telephone evaluation is good enough. You don't have to come back to the center. So we can call and the patient and get the scale, same quality, same assessment degrees. So that's what we planned. And so I'll show you very important internal consistent means about 12 subscales. 12 subscale, one is very sensitive, the other one is not sensitive. That's not good. About the same way they have to move. That's what called internal consistencies. We use Cronbach alpha, which was 7.76, which is clearly good level, acceptable level. And then we did the test retest in primary test retest means intra-rater scale, and then primary to secondary rater did the scale, which is inter-rater, and then also primary to telephone, which was very good, but the telephone to telephone was not so good available, but I think that's the reason we decided to do same person to call to get the telephone result. But any case, test retest was quite acceptable, and we are happy with this result. And then also construct validity. Construct validity means when you make a new scale is testing with other well-validated scales. So new scale is acceptable compared to other scales. That's what we did using QOL called patient-reported scale, and also Schwab-England scale, which is ADL scales, only 10 scale, and then we looked at arm, leg, and total, and all level is quite acceptable. So we are very happy that construct validity was well established. That means now we can use this PLS-FRS. New scale is a scale for PLS. So now we established the baseline in 3 weeks we call baseline, and then is it sensitive to change over time? And usually we did PLS Cosmos studies, of course, which study was funded by SPF, and we did a 2 years change, in 2 years a change with PLS-FRS was tiny change. So we have to see how much we can expect changes with 6 months or 1 year. So this is the 6-month scale, and you can see all those, sorry about these tiny numbers, but the nutshell is a confidence interval, almost everything is negative. That means clearly significantly scales are going down with the time. So I'll show you, this one is 24 months, 48, 52 months, 2 weeks, 1 year, and 1 year scales again, all confidence interval moving down, so clearly significantly going down. And also we looked at PLS-FRS significantly using statistical analysis lowered. So we enrolled 77 patients, and 62 patients followed up to 1 year, and some patients actually dropped out and cannot come back and do studies and so forth. But this is now demographic data, male, female, and age group, and the disease duration is, as you see, tremendous difference, 2 months to 287. Why? Because any patient who are diagnosed with PLS, we included the studies, and again, reality is cannot choose a certain period and so forth. But I can show you those even big difference range from 2 months to 289 months. Still, our disease seems to be moving the same way. So you can see some changes in graphs. So comparing with the PLS-FRS, I can see lower box is the PLS stop and PLS-FRS and the second, and clearly now this is the 6 months and the 12 months. PLS-FRS is more significantly better, about the 4% is better than PLS-FRS-R. Again, now this one is showing total score and moving continuously getting worse, and as you can see, difference between PLS-FRS and PLS-FRS comparing is about the 4% is different. So and also statistically difference with PLS-FRS is far more sensitive and superior compared to PLS-FRS. So we are pleased that this new scale is a sensitivity detecting changes. Those detection were done by all of the phone from Columbia University to entire patient involved with 20 centers. So we looked at also 10 early PLS, and early PLS means less than 3 years. We usually don't call PLS because too early, yet 10 patients are such range, and we looked at the changes of those changes, and it looks a little bit less than typical PLS, but again, those are small numbers, and I think they are still clearly changing over the time. So what we summarized is internal consistency, construct validity, and test retest. That means in person and by telephone, reliability of PLS-FRS has been fully established. And we reported this is MND ALS symposium last year, and just we got the result February, and the data cleaned, and we gave data set to biostatistician April. So we are just in the middle of getting new data, entire data set, and just we are starting writing papers. So PLS was significantly better at detecting changes, although modest, over 12 months compared to the PLS-FRS-R. Study duration of 12 months could be sufficient to test the efficacy of a potential medication in the future. This is most important. Even 6 months clearly changes significant change, yet 6 months might be still a little bit causing anxiety if I use clinical trials only 6 months for PLS, but now confidently 12 months should be sufficient to test new medication for patient with PLS, so we don't have to 2 years. So that is quite promising. Yet maybe in the future we can try 6 months. Further understanding of PLS is necessary and helpful for developing future clinical trials in PLS. Of course, the scale is the scale. We have to use quantitative measurement and so forth. So we are ready to do clinical trials if a medication is available. It is possible to use PLS-FRS, which is more sensitive in clinical trials in ALS, so that study period can be shortened, although future studies are warranted. So we still study because we have not tested PLS-FRS in real world, and real world means real clinical trials. So we have to test, and comparing with the quantitative such as walking time and peg test or foot tapping and finger tapping kind of continuous measurement compared to PLS-FRS will be important. So why I have not fully answered why we developed PLS-FRS, and so the reason why we did the PLS-FRS was we submitted the PLS grant, which called clinical trial readiness for neurodegenerative disease, and this was RFA, means NIH asked us to apply new applications. So PLS is a rare disease and a neurodegenerative disease, and we might be ready. So we made grant application, and but because PLS is so rare, we don't know the cause, we don't have any biomarkers yet, and so even we don't have any good scale. That's the reason we developed the scale. Well, the grant was not funded. So twice was not funded. Then I realized, well, PLS is too early to get NIH grant, and that's true. And if that's too early, we have to much more learn about this disease, and why not to get all international experts to get together to learn and publicize. And so that's the reason we did the second international PLS conference. So just I go back to history of the PLS. I wanted to tell you, I'm sure most of you know those, but PLS was described by Jean-Martin and Charcot, which is really a father of neurology. And the 1981, Bill and Richardson, who were Mass General at Boston, and described the case of PLS with autopsy, which was the really first time to introduce PLS in the United States. 1980s to 1910, several ALS centers independently collected the cases and reported. And in 2002, Spastic Paraplegia Foundation was established and cover not only HSP but also PLS. 2004, first international PLS conference held by Dr. Siddiq in Chicago, and 2012, and 5 multi-center PLS Cosmos studies initiated, again funded by PLS. I was a PI, and 2015 one-day PLS conference in London. Martin Turner was essentially held conference for the patient, and so there is a interest, but the first conference was 2004. So NINDS PLS clinical trial readiness was not funded, and taught me how we have to work on PLS. Still, we have to. So that's the reason 2019 we held second international PLS conference in Philadelphia, right before American Academy Neurology meeting. So what is PLS? We already talked about, but I think it's also unsettling things is we are told, don't make diagnose of PLS until you wait 3 years. And Paul Gordon, who is one of our associates, also said, no, 3 years not enough, and let's wait 4 years, along with Dr. Roland. So what is from symptom onset to 3 years, 4 years? You have a problem, you have some kind of disease, but not a PLS, not the ALS. What are they? So it's extremely frustrating how we deal with undiagnosed stage. So I'm going to show you this slide. This slide is actually not PLS, this is ALS. ALS is a lot of hypotheses. We still don't know the cause, but so much genetics now, so much oxidative stress, mitochondria, and you can see inside full of all those hypothesis explanations. Some are very good, some are still primitive and so forth. But when we talked about PLS, we wipe up everything here and just show neurons and nothing. So we do know nothing about the PLS yet, unfortunately. So what do we know about the PLS once again? So incidence is so rare. Probably by calculating, I see 100 patients with ALS, probably 1 or 2, maybe 3 turns out to be PLS. So by calculating, probably we have 125, 150 new PLS patients, and the patient, probably 2,000 patients in this country prevalent, means they are alive, they have disease and so forth. So it's a rare disease. So cause and pathogenesis are unknown. Nosology is unknown. Is it ALS or independent disease or spectrum? We don't know. So natural history limited knowledge for long-term prognosis and outcome. Still, we need to know. And the clinical features variable. For example, clinical description dominates the literature. Diagnosis still uncertain, particularly in early stages, as I mentioned. Assessment, upper motor neuron scale is now being developed, and PLSFRS is now being developed, already developed. So we have now tools to tackle clinically with the patient with ALS. Neuroimaging most progressed in relation to ALS studies. And also neurophysiology has an important tool for diagnosis. Biomarkers, iffy. We have developed some biomarker for PLS, is not quite reliable yet. Well, might be, but genetics is rapidly progressing, and the clinical trials are still never done, but probably will be done very soon. So international PLS conference in terms of promoting research in PLS, knowledge, current knowledge, and future challenge. That's what we organized. So we got the fund, of course, from SPF and a couple of industries, NIH and ALS Association, British MND, and so forth. Of course, Mr. Moran funded, and so those are secured 3 days meeting. 2 days meeting, and what do we expect out of this conference? So this is the real slide I showed at the time of conference. Increase awareness of PLS, increase our knowledge, and increase networking, and expand research in PLS. But also, I asked those who attended the conference, please think on throughout the conference, what are the cause of pathogenesis of PLS? That I want them to think constantly by listening and answering and discussions, what's the cause and pathogenesis. So also at the end of a meeting, I need some action items, not just the meeting itself, that's end, nice meeting, but that's not good enough. We have to have some action items at the end of a meeting. So this is small letters, just out of program, sorry, but May 3rd and 4th, 2 days right before American Academy meeting, and first speak with clinical spectrum. So what do we know about clinical spectrum? Know about registry from United States, and also Germany and Holland, and we are talking about more registries, but there are a number of countries has registries for PLS. So we asked Dr. Fink, what is not PLS and what is not ALS? We asked Hyman Patterson, and also what is Mills variant, and we discussed. All speak is only 3 minutes. And we did this conference before, funded by NIH. Only you have to give us 3 minutes talk. And I think if you cannot talk 3 minutes in summaries, you are in big trouble. You just don't have any message. So very short. Everyone loved this conference, and because it's short. and then most of the time discussed just open exchange. And so Dr. Fink is there, so he can tell you whether that's true or not, but that's what we did. And in the second session was the cognitive impairment. As you know, as you know, ALS impairs the frontotemporal, some degrees, and some are severe, some are nothing, most completely unaffected. But PLS is also very similar degree frontal temporal lobe impairment. So what's happening? That's what we discussed at Dr. Murphy and also Ted Huey. And again, most of the time we discussed how we do it, how you measure, and so forth. We discussed both sessions. So next session is electrophysiology, and electrophysiology is very important to make diagnosis. By definition, pure upper motor neuron means lower motor neuron is not affected. EMG, electromyograph, is the best test to detect lower motor neuron changes, weakness, atrophies, and muscle twitching, and so forth. So those tests are very good. So technically speaking, EMG has to be normal. But experts always argue what's normal. This is normal, this is normal. It's not agreement. So that's what we discussed. That's the EMG. Second physiology is transcranial magnetic stimulation. It's a very important studies. Only United States, NIH, and Columbia is doing this transcranial magnetic stimulation. Now it's increasing a little bit, but you can look at Australian group is incredibly sophisticated, looking at sensitivity and also excitement of motor neurons by special techniques. So that means if they do special transcranial magnetic stimulation test, they can do how upper motor neurons are excitatory. Constantly, there are more jittery type of changes occurring. So those electrophysiological tests is very important. That's what we did this sessions. And the next session, the neuroimaging. As I said, the neuroimaging is most advanced, and because you put the patient into PET scans or MRI scans, doing all kinds of sophisticated analysis, you can see changes in PLS, and sometimes comparing the ALS may be different. At the moment, very difficult to separate out ALS and PLS because both affect upper motor neurons. Yet there are possible to separate out the PLS and ALS in neuroimaging. So neuroimaging is probably most advanced and very promising. That's what we discussed with these sessions. So again, how we measure PLS, we presented PLS-FRS and also how to measure patient quantitatively. So that's what Pat Andreas discussed, and also so those two issues we discussed, and we are ready to select those quantitative measurement and the scale. And for example, I have to remind you that PLS-FRS-R for ALS is so important. For example, every clinical trial using PLS-FRS-R as an outcome. Some are primary, some are secondary. But now new medication approved a year and a half years ago, which called edaravone, was approved based on PLS-FRS-R. So what I'm trying to tell you is PLS-FRS is probably, hopefully, such scale in the future for PLS is a very important scale to study clinical trials. Well, that's what I hope. But in any case, we also talked about biological biomarkers, and Columbia group looking at lipidomic changes and Estella thought now we can separate out ALS and PLS. I think that has to be repeated by different samples, and very promising, very exciting. And also Dr. Giovanni, who is a mitochondrial expert, did this mitochondrial bioenergetic studies in skin fibroblast, and that is, we have almost all patients from ALS Cosmos, PLS Cosmos patient. So he studied, and mitochondrial energy formation is clearly more exceeding than ALS. So it's not the same, it's different. So that he repeatedly reported, so that's a very promising. So the evening, actually, Mr. Maran funded, and we had dinner at University UPenn, and called Hall of a Flag, and we had after dinner debate. G.C. Andrews moderated, and Eric Piero and Dr. Di Cavajo and Dr. Flota and Dr. Hyman Patterson, all those, excuse me, sorry, Dr. Alderman participated debate, and this is actually after dinner. People a little bit went to upstairs to see a hall, so we have just a part of a team, but actually we had 75 members participated. We had really great dinners. Now, next day, we talked about the genetics, and so what's the familial ALS and familial PLS, all those genes, and TPU, and also Guy Rouleau discussed those genetic issues, and Matt Harms discussed genome sequence we did for PLS Cosmos studies. That's what I think gene, genetic, and molecular mechanism are clearly progressing. Part of talk we already heard from Dr. Blackstone. And also we had a keystone speaker and neuropathologist, and Mackenzie discussed 1 hour about neuropathology and PLS and ALS and the frontotemporal degeneration and so forth. So understand morphology is so important. That's what we did. And then after this meeting, we had clinical trial sessions. Merit Sukovich moderated the sessions, and I gave a little bit talk, experience from clinical trial readiness, and so also she talked about the current platform clinical trials in ALS. So I think it's clinical trials are still not starting, but not that far future. So also we had trainee young investigators presentation. Always we invite young investigators which less than 5 years after residency or fellowship, and they don't have enough funds, so we invite them, and we hear what they do, what their plan, and so forth. It's about 9 people, and Frank Davis presented all of them, and we heard what their future. We wanted to stimulate young people to move to the field, because young generation is our hope, our future. So that's what we have to foster them. So afternoon, we did a panel discussions. The panel discussion is there. So how we make diagnosis of PLS, they're debatable. We have already diagnostic criteria, and diagnostic criteria, I told you, you have to wait at least now 3 or 4 years to make a PLS. So it's extremely frustrating, at least in my mind, it's so frustrating. So how we can change, and Martin Turner took big responsibilities. Now he's emailing to all people involved and making new diagnostic criteria. So that's what's starting from this panel discussion. Second panel discussion was international PLS registries. we already talked about prospective or retrospective registry for PLS for United States and Ireland, Netherlands, France, Germany, and also Japan. So those are presented and how they do it. A hope is, I think, a new prospective means new patient has to be registered, and so that's what we hope we can accomplish. That's what we discussed for the second panel discussion. The third panel discussion was suggested by Robin Conwit, and we want to hear what we would like to see for the future. So this was a very exciting panel discussions. For example, I'm sure you know Sabrina Paganoni, who's from Mass General. She presented a number of times her studies and so forth. She volunteered to have a meeting every year, every 2 years. So we are excited to have meeting repeated. And also Toby Ferguson discussed where we move, and everyone discussed where we move. So that's what I think exciting meeting, and I got a lot of good comment. So I'm very pleased. But that's not the end of it. So outcome of this international PLS conference, we have to repeat. The last conference was 2004, so it's a long time ago. So that's too long. But every year is maybe a little too close, I don't know. But I think we got to repeat this conference. So we have to update PLS diagnostic criteria. And as I said, Dr. Turner is leading the effort, and a lot of different characters, personalities, organizing a different, very strong mind to set the diagnostic criteria is not an easy task. But he said someone has to do it, so he's willing to do it. Already for our conference, we have 3 editors of journal, muscle nerve and ALS FTD journal, and also JNP editors were there. So Matthew is interested in publishing this diagnostic criteria. And publishing a supplement for to ALS, that's what we discussed. And Ola Hardiman was very much interested in publishing supplement for her journal. And so now we are working. We have now table of content. Essentially, it looks like a conference, but making it to form a supplement. So I think is now paper should be due sometime in early fall. So I asked Martin to help me to edit entire supplement. Yet I think is each section, as you saw, moderator, each section is responsible. They have to make one uniformed paper. So that's a big task, but I think we are going to publish, and I think that will give current status of PLS for many ways. So I would like to already formed actually international PLS study group called PLSG, and this is really different segment, neuroimaging, neurophysiology, genetics, and biomarkers, clinical trials, and measurement of disease, and many different area. We have now a study group, and the director or chair of study group is already identified, and I have to move more forward to how we do it. But I think this is very important to move this study group. And then Dr. Robin Conwit had a meeting, few of us, and discussed that she really wanted to move this rare disease forward. So how she does, at least if she can get additional fund supplement or whatever supplement to current NIH grant, such as CREATE, the term CREATE by Michael Benatar has this grant, so we can supplement NIH grant to do. We have skin cells from previous ALS Cosmos studies. Those skin cells can convert it to motor neuron. Just we saw Dr. Blackstone's slides. We can convert now to make neurons. So study those PLS motor neurons to biological fundamental mechanism of the disease. We need a clue. We need a stronger clue to hang on or study more for PLS. But I think we got this clinical scales and clinical conference. We are very different from last year, and we are moving to direct ourselves to find out the cause and hopefully treatment. So really appreciate your support, and without your support we cannot do this kind of thing. And so really I'm truly grateful. Thank you so much. So you're asking dollar figures?
Sorry?
Dollar figures, how much? That's
dollar figures. Just generally speaking, like how much overlap is there between, ALS and PLS, the research that's being done, and if it's easier to quantify in dollar figures, great.
Right. I think we can do two separate ways. So if we have a potential medication, and there is no medication specifically for PLS, and people says, even the grant review says, well, some reviewer means, I'm sure reputable scientist says, if we find medication which works for ALS, should work for PLS. So why you have to do special effort? Just to develop a medication for PLS, you can use for, medication for ALS, you can use for PLS. May not be so, because this is only upper motor neuron, and the reality may not that simple. Of course, we should try. Any medication works for PLS, we can try, but it takes a long time and so forth. So if we have medication, even used for PLS, medication available, we should try for those who have this disease, PLS. That's one. But the second thing is extremely important to develop prospective registry to see how disease in terms of biomarkers, clinical and physiological, neuroimaging, if we got all those data to follow patient. But we are talking about a rare disease. I see only few new patients at Columbia. The Columbia is one of the largest centers in ALS. So such a rare disease that as I said at the beginning, we have to work together, multi centers, multinational centers, to do same study, see how patient. Natural history is extremely important. So money will be costly, of course, and I don't know how much money it costs, but I think it should be done, and it needs to be done.
Great question, great answer. I'm going way over here to the right and working my way back to the middle. And I'm tiring. I'm slow. There you go.
Is there public access to the PLS-FRS outcome measure?
Actually, a couple of doctors, one Italy, one in Netherlands, asked me to use, so I gave it to. But I think it's now I'm writing a paper, so published. And if you're very much interested, then please email me, okay, and I'm happy to provide. Of course, if you don't publish any of those data, but I think we're happy to provide. Yes, indeed.
Okay, thank you.
Great. Got one more here in the middle and one in the back.
Two things. One is, it would seem to me that, I'm not a scientist, it would seem to me that PLS is half of ALS. Why not focus in terms of only affecting the upper motor neurons? What I'm sensing from you is that you're doing focused research in PLS. Why can't we get more funding into that? Because it's only half of ALS. I would think, we heard when Karen was diagnosed, oh, you don't have ALS, you have PLS, that's a good thing. What they learn in ALS, they'll apply to PLS. Why not apply that in reverse? What they learn in PLS can apply to ALS. And why is there so much, and other motor neuron diseases, why is there so much, why are we stuck in that space? That's my first question. The second question is, as a patient, as a PLS diagnosed patient, I understand from a science perspective, from a doctor's perspective, there's ownership in that science. There's a lot of benefit from owning that science. But as a patient, we're finding that it's difficult to get involved. It's like, we want to give you our blood. We want to be part of this. And there's this resistance. There's almost a boundary there. How can we as patients participate more actively in getting our information spread to you meaning the whole community within the PLS world?
Make a shared central depository for our data.
Right. I understand. I think that's not just issue for PLS, but every science, ALS and so forth, the same way. But PLS is a far more rare disease. That might be difficulties. I'm not trying to defend myself. I'm trying to break those barriers to move on. But if I see rationally, reality is PLS is so rare, that's the reason. And also, as I said at the beginning, PLS is not issue of survival, but create lifelong terrible motor dysfunction. So why not half and half put effort? That's the reason I'm emphasizing. Look, if you study PLS, you understand upper motor neuron disease problem. So yet I think it's, for example, MDA, famous MDA, a few years ago decided not to fund PLS. I was shocked, and I was getting a grant from MDA, and yet now they decided not to fund the PLS. PLS is not ALS. So I think is still a lot of a problem to understand the PLS. I think it's use this kind of organization, SPF, and yourself, publicizing, and to go to capitals. And I think it's a voicing your, really raise your voice is a key. I think that's the way you have to do. But data sharing is always now difficult, even de-identified data. IRB, Institutional Review Board, getting harder and harder and harder. And for example, we did big epidemiological studies, ALS, and 355 patients. The number looks small, but we wanted to send that data to other centers to analyze. Can't. They completely barriers, this and that constantly question, impossible to share the data. So those are greater goodness for the patient and science. And confidentiality somewhere needs to be understood properly. So that's what I think needs to be done. It's indeed, we have a lot of difficulties.
Great, we got one more back here in the back.
Yes, great presentation, and I was taking notes. My question has to do with the rating scale, and I think that's a significant advance. And you showed a slide that showed a decrement over time. And I'm very interested in that, and I'm wondering...
I'm sorry, what?
The rating scale.
Yes?
You showed a decrement over time.
Decremental?
Decrease over time.
Over time, oh yes, yes.
And I'm very interested in a comparative group, such as control subjects or spouses. And my question has to do with this. How much of a decrement is due to the condition versus how much of the decrement is due to the age effect or comorbidity and pain and decreased exercise? So has the PLS-FRS been used in control groups with similar disabilities or similar degrees of age and inactivity?
Well, such a good questions. Well, for example, we use PLS-FRS for ALS, and those when you look at patient, there are fluctuation, but steadily getting worse, decrement. And PLS also show decrement. And just simply, I thought those are just expressing disease worsening over the time. But your questioning might be some other factors. So I think that's a very important and that question that I cannot answer at this moment. But I think it's, as I said, PLS-FRS only established a scale, one, and also showed scale can change with time. I think those scale has to be tested in real world clinical trials or multiple clinical, PLS registries to over time, how they do it. And so we should not ignore patient age, other factors, as you mentioned, to see any effect influencing PLS-FRS scale. So I think that's an incredibly important suggestion. Thank you so much.
Okay, everybody, we're going to wrap that up. Ladies and gentlemen, Dr. Mitsumoto.